start rolling and go from there.
Okay.
Let's do it.
Well, we're all interactive, so if you guys have questions, be sure and stop me on the way through it. We'll go through it relatively quickly, but at the same time, give you something to think about. All right. Well, anyway, well, welcome. We're good. We're good to go, Tom? Yeah. Okay. Good. It's always interesting to speak through a computer, but at least I can see you. That helps. At least we have some feedback here that I can gauge my presentation on. So thanks for joining, everybody. Our time's pretty valuable as dentists and whatnot, so I won't waste your time. Thanks, Dr. Casey, for getting me hooked up to do this. These are all your contacts, so I appreciate the help.
No, I appreciate you putting together a presentation over the weekend and keeping us from not jumping off a building or something. This is always more fun learning something.
Still early in the day.
Yeah, it is.
Exactly. Well, that's everybody's hot topic is the COVID-19 issue. It's out there. I guess all I would like to say to everybody is I wish you good health for you and your extended families, your practices and whatnot. At the end of this, we'll get through it. We'll open our practices back up. And I do think once we do open back up, it will be slightly different. I think Tim and I talked about that the other day a little bit. We'll have to make some adjustments because I think the whole world's going to make some adjustments after this is over. But enough on that. I guess my thought process is in the last 25, 30 years is I think in business, if you can provide a solution to a problem, whether it's in the implant practice or whatever it might be, you can grow a business around that help. And that's kind of what I intended to do in the last 25 years and had some success doing that. So we'll share some of those experiences. I always say to people when I'm doing a presentation, I like to have full disclosure. I always want to know who's talking to me when I'm listening to someone talk. What's their interest? What's their conflict? How they get where they're at. Are they in clinical practice now, or are they talking about something that was 10 years ago? So those things matter, I think, in a clinical presentation. So I just want to be honest with everybody and let you know kind of where I came from, what drives me, and where I intend to go in the future. But I do make a pretty good living on implants and implant-related services, and I'll just quickly run through the experience I had. So like all of us, graduated as a restorative dentist in 1991, built a fairly large general practice doing everything in a small community. This building you saw here, we built in 2001. And it was a town of 9,000 people and had 13 chairs. So we did a lot of implants, ortho, TMD, tried to be the master of everything to everybody and had some success with it. It's certainly a practice model that works. But that's how I started, like all of us probably did. 2004, I started teaching a course at LVI. And in that program, we do a lot of surgical restorative. Tim knows about that and other things that relate to all the other things in dentistry that are implant related and otherwise. In the last 20 years, did a lot of presentations for Zimmer, Dentsply, BioHorizons, other big implant companies before we started our own game here, and we'll get into that. 2005, we did a treatment planning service, put the first 2 mobile CT trucks on the road in 2005. So you can see the whole journey is related to implants and implant-related services. So we did a lot of treatment planning. That was really when it was first introduced. 2004, 2005 is when the CT machines and the treatment planning software hit the market. So been in that game for quite a while. 2010, we started an implant company. Don't ask me why. I'm not sure. I still know why, but we did start an implant company in 2010. I guess the main reason I started, I was using the ankylous implant at that time. It's a German implant. Thought it did a lot of things that the other implants didn't do. Tried to get them to make some changes to the system, wouldn't do it. So apparently one night decided that we should start that ourselves. So that's how that journey started. Really had no idea where we're getting into, but it's been an interesting game, I'll say that. The same time, 2010, my partner and I just started a machining and manufacturing company called AMS. And that's functioning yet today. So that was in 2010. 2014, just a quick journey. This is the practice that I'm in now. On the slides there, you can see that's the waiting room. The 2 slides on the left, 2 different views of the waiting room. What's different about an implant practice is just less patients in the daytime and more directed towards obviously one service. So that's where we're at. It's on a river town, and it's in this facility in the corner of the building here in La Crosse, Wisconsin. All right, this is the room I'm sitting in right now. We do a number of CE courses here locally, and it's more of a personalized approach to implant dentistry. We show doctors how to do the surgical and the restorative side. Behind this window in this room is the surgical suite. And again, we videotape surgeries and broadcast it out. People come in the operatory. So that's more for a personalized approach. 2015, I started doing a training program in the Dominican Republic. And this picture on the left here is 6 chairs in a row where doctors come down and do as much surgery as they can for 4 days. And then there's a day of lecture before that. So it's a week program. Probably the best program I've done in education, I think, because it's not me doing it. It's all the doctors coming down, participating in whatever surgical experience they're trying to capture. So we get dentists down there that have placed no implants and want to place their first 20 implants or so. We get doctors that have placed a lot of implants and want to come down and do lateral sinus grafting, ridge augmentation, ridge splitting, things like that they haven't been exposed to in their clinical practice. So I do think it's the best thing I've done in practice, because I see doctors going from whatever level they're at to the next level pretty quickly in a week's period of time and go home with a lot more comfort. So again, it's a way of giving back to the community, and everybody does that. So it's basically 12 doctors at a time. You assist the doctor doing surgery, and then after that surgery, you switch sides and do your own surgery. That's how that program works, basically. 2017, the guy that owned that, Dr. Rio, he's the guy in the center here. He built a new facility, so that's quite a nice facility in the Dominican Republic. Same number of chairs, 6 chairs, 12 doctors, and we're working through that process. 2019, just last year, we built a new manufacturing facility because we ran out of room in the one that we were in. So this is what we started in 2019, and that's what it looks like today. So we opened that back in August of 19. It's kind of a misleading picture. It really doesn't snow in Wisconsin in August, but that's a picture that was taken recently. So you get the idea. It's a 30,000 square foot facility, and inside it looks something like that. That's one of the rooms that are in there. But there are CNC machines, and how a dentist got involved in all that, like I said, I might have lost a bet, but that's what we're doing today. We're making implants and medical products, and we have, I guess in my 2 businesses now, about 45 employees. So just like all of you, we're a little concerned now about keeping these people working through this process, however long it takes. But that's the machining and manufacturing, and we do, like I said, a lot of dental implants for other implant companies. I don't know where all the implants end up, but it's not just implants, it's medical products as well. All right, I have 5 children. Those are the 5 kids on the left. That's when they were young, and my wife Lynn. So we've been married a long time. Those are the 5 kids. They're all grown up despite their parenting. And the one here in the middle, or not in the middle, but almost in the middle, is Rachel. She's in practice with me now in the implant practice. And the rest of them are in either graduate school, law school, veterinary school. One's a geologist and one's in undergrad. So quite frankly, that's why I work, because they're all needy, and I'm trying to support that habit that we developed years ago. All right, so we had 5 kids in 6 years. All right, so that's kind of a summary of where I'm at. Everything I do is kind of related to implants. So these conflicts of interest I say I have are also what gives me kind of an overall global view of what's going on in the implant world. But I think when you listen to somebody that owns an implant company, that owns an implant practice or whatnot, you have to sort through what's said and make sure that it makes sense to you. I always say if it's true for you, it's true. If it's not, it's not. It's kind of your job, I think, anybody listening to a presentation, to decide what makes sense, what doesn't, and filter out what would be useful for you. I also always say, though, don't be afraid to change your mind when it comes to any part of dentistry, because we all know how fast this thing's changing, especially with the digital flow that is out there now and running pretty heavily. So in the last 26 years, implant dentistry has changed dramatically. I think we can agree on that. Products have certainly evolved. Processes have changed with the technology changes. Digital advancements like CBCTs, treatment planning software, digital impressions and models, CAD design software, and CAM manufacturing. Those are all the things that have totally changed how I do implant dentistry today versus 10 or 15 years ago. They've certainly made it more predictable, simpler in a sense than it was before. And I always say to people, if you quote me, date me, because what I did 10 years ago isn't at all what I do today in clinical practice. And I think you could apply that to most things in dentistry today. Having said that, though, there's still significant challenges and plenty of misinformation in the implant process. Like I said, guys, if I say something that doesn't make sense, stop me. So what is the future of dental implants? What do we know for sure? Where are we going? What are we still confused about? And how successful are implants? Because if you're going to, I always say, if you're going to do something in clinical practice, if you're smart about your clinical practice, you do things that go well, and you filter out things that give you trouble and get on to your next patient. So that certainly applies to implant dentistry. So what are the most dangerous procedures almost all of us do in dentistry? What would you think that might be? Well, if you look at the literature, it's given local anesthetic to patients of all different shapes, sizes, and degree of health. So again, I think that's something we do every day without giving it much thought. Just to get your mindset on that. What else do we do that's really dangerous every day without giving it much thought? We run a handpiece in people's mouths at 40,000 RPMs. And if you think about the things that could happen based on that, it would probably scare most people. But here's the caveat. Literature shows that about 85 or 90% of the dentists that run those handpieces at 40,000 RPMs are afraid to run an implant handpiece at 1,200 RPMs. And it doesn't make a lot of sense when you think about it. So there's something about implant dentistry that scares them and has kept most dentists out of it. So I think I have a good understanding what that is, and we'll talk about it as we go along. Before we get into it, have you ever heard the expression from a dental implant company or from a speaker that 90 to 95% of implants are successful? Do you believe that to be true? Do you find that to be true in your practice? So virtually very few dentists place implants, but almost every dentist on planet Earth that has a restorative license or a dental license restores implants. So why is that? Why is the restorative process seem safe? The surgical process apparently is unknown. And I think that's what's changing a lot in dentistry. We'll get into the reasons why here in a minute. But I do believe why most dentists coming out of dental school or have been out for 20, 30 years don't do it. They were taught not to, quite frankly. We were taught not to do a lot of things. Surgeries can be difficult, and they can be. There's certainly a lot of costs, and the cost equations that go into the thing, and implants certainly can fail like anything else we do in dentistry, period. So all that I think leads to a lack of confidence to start, and it's pretty well ingrained. That's why we're at 15% of dentists participating in the surgical side. The technology, I think, can change a ton of that. It is simpler, more predictable today. So let's talk about implant dentistry today, and let's talk about what potentially, if all I do in practice is implant dentistry, well, how do I do it? And what do I do? At the end of the day of a presentation, a lot of people want to know, well, what do you do? What products do you use, and why do you use them? Are we okay, Tom? Okay. You guys heard me okay, everybody? Okay, good. All right, so 2004, that's when the CT technology kind of hit the market. So CTs, and they're a lot more accessible now than they were 10 years ago. And the treatment planning software, those are the two things that really revolutionized the implant dentistry approach in practice. And not that every implant that gets placed gets used by these, it's still a small percentage, maybe 10 or 15% of the implants placed today, people use this technology. But I will tell you it's a solid approach, and it's not going anywhere. So if you look at implant dentistry as a whole, what are we trying to do? We're trying to take a three-dimensional view, a cross-sectional view, decide where the crown goes, and decide where the implant goes, and replace this drill with an implant, that part of the drill with the abutment, and that part of the drill eventually with the crown. So it's quite simple. If you understand how to read a three-dimensional view, you either have bone or you don't. You're either going to place an implant there or you're not, or you need to do something like augmentation to develop that site. So if you're new to implant dentistry, having this information presented to you or in front of you before you ever start is a lot different than the way I started 25, 26 years ago. You know what you're getting into before you get into it. But the technology, again, has evolved past that. So if you look at this CT X-ray, it pretty much shows you what we look at. Here's a proposed final restoration. Here's the bone we have above it, you know, the buccal view, the crest of ridge, the palatal view. Can you place an implant to hook up to that crown when you're all said and done? And it really is that simple. So you could turn that data from the CT machine and the treatment planning software into a surgical guide that directs your drill, or into a surgical guide that directs all 14 of these implants. So all that technology, if you understand kind of what you're looking at here and you understand you can turn it into this, that's really guided surgery, and that's where we've come. All right, so you don't have to make an incision, look and see what's there, then make a series of judgments on how to put the implant in if you look at that approach. Now, I just got done saying that's 10, 15% of the implants placed today. The other 85% of implants placed today are done off a two-dimensional approach. And I'll be the first one to tell you, it works. It just requires more understanding of the process as you're doing the surgery than the information that you received before the surgery. So if I was doing a case like this in my practice, we're going to put an implant right here where the tooth was lost. How would I actually do that? Well, I have a CT in my office, so I would take a three-dimensional view. Even if I wasn't turning it into a surgical guide, the view itself tells me ahead of time what implant can I put in there, what angulation, what orientation, and you could still go in and lay a flap. So could you do this without a three-dimensional view? And the answer is absolutely. 85% of implants put in are done that way. but just giving you this image gives you more information before you start. So if you treatment plan in this case, you could go up and you could pick out the size of implant you're going to put in, 3.5 by 12, place in that position. And then we don't have a crown in the software here, but we could put a crown on it. But if you look in the axial view here, your abutment lines up with your adjacent teeth. So before I ever touch the patient, just from that x-ray, whether I turn this into a surgical guide or not, I know that it can be done. I don't have to wait and figure that out after I make an incision. So that's the real advantage of the CT scan, which is half the equation of guided surgery. So CT driven, non-guided surgical procedure, and that's how I place this implant for this patient for whatever reason. But if we were going to do that, this is how you would place a freehand type implant placement. Make an incision, reflect the tissue out of the way so that you could see the bony anatomy, draw from your memory what the implant size was and the orientation of the implant, and then basically direct a purchase point with a lance drill is generally how I do it. So you can see the purchase point there. It's in the middle of the ridge. It's in the middle of the space between the tooth ahead of it and the tooth behind of it. And buccolingually, it's pretty well centered and localized. So that's all we're doing. We're doing our best job we can of missing the roots of the adjacent teeth. We usually go down with a pilot drill, with the first drill about 8 millimeters, put in a parallel pin that you're seeing there, and verify that you're mesial distally correct from that x-ray. That's all you can see. And from a clinical viewpoint here, you're going to try and make sure you're not perforating through the buccal or through the lingual. So there's a lot of unknown, but there's a lot of known based on the original x-ray that we took. So when you're all said and done, you drill to a certain length, verify that you're at that depth before you place the implant, and screw the implant in. And like I said, is it successful? Of course it is. Are there reasons or places to fall down? Of course, but with any surgery, that's the case. But when you're all said and done, you got a pretty nice result here from a single x-ray, and with some experience that's relatively straightforward to place implants that way. So if you're getting into implants, I always say to people, is the first thing you should do is go out and buy a CT machine? Well, that's a pretty big hurdle to get over. Pick cases that are straightforward, put your implants in. Eventually, if you do a lot of implants, you'll buy all the equipment you need to support a three-dimensional approach. But you could put on the healing cap when you're all done, close it back up, do a second stage surgery. That's what you're looking at there. The healing cap's placed. If you wanted to put on a cover screw, close this back up because you had poor stability, you could certainly do that. So both of those approaches are available. You're going to close the case up and then restore it at whatever sequence or protocol you're trying to accomplish with that patient. And that restorative space, we'll get into that a little, or that restorative time. We'll cover that a little bit before we end up. With the technology and the equipment that's out there today, that restorative time could be as few as 6 weeks. It could be as long as 6 months, depending on the situation. So there's your final PA. Shows the implant placed in a pretty good position. You'll notice this implant's placed subcrestally, and that's something that's relatively new to the U.S. We have implants now that have the capability of placing at crest or below, and there's some significant advantages with that when you're doing surgery. All right, so guided surgery, let's just cover that real quickly. This is normally how guided surgery works. You take a traditional impression or a digital impression, you scan the patient in the CT scan, and then you have two files. You have a DICOM file and you have an STL file. Those two files get merged into a treatment planning software. And the treatment planning software, then you go through the sequencing of treatment planning. We're not going to go through the steps, but just give you the overall view. And eventually you make a surgical guide. And when you do surgery, you're doing it through a little hole that guides the implant position. So there's a lot of variable ways to get there, but they're pretty much all the same. That's where you end up. So if you have a patient like this, an orthodontic finish case, you see the problem. So this was referred into my office. Let's put an implant in there. Well, you don't need a CT to tell you that that's not going to work out. There is no room there for that to work. All right, so you send it back to the orthodontist. She makes as much room as she could and sent it back again. But when you have a case like this is a good argument for guided surgery. Could you freehand this case? And the answer is of course. Could you do it more predictably if you did guided? Of course, because if you look at this case, you're going to violate every rule out there when it comes to implants. The implants are going to be too close to the adjacent teeth. There's not going to be space between the teeth, between the implant. But if this person went through ortho for 4 years, I think, with the whole purpose of putting an implant in there, I'm not going to tell her she can't have it. So we are going to bust the guidelines sometimes to give a patient what they need. But it's a good case for guided surgery because you don't have any room for error. So this is basically the surgical guide. We went through the treatment planning process. and then we're going to do guided surgery and place the implant in the best position possible based on the workup. Obviously, surgical guides can be wrong, so trust but verify. That's what we're doing here. We've done the pilot drill. We put the parallel pin in. We're verifying, even though it's guided, that things are correct, and we're going to work through the process. So when you're all said and done, there's your implant placed. We're placing it at a certain depth, certain angle. You can see we placed it in the lingual line angle. That was really the purpose of the guided surgery, to idealize the position of the implant. And there's your final placement. Again, placed quite a bit subcrestal. When people see this slide, sometimes they say, well, why did you place it so deep? And probably place it that deep because the top of the ridge in many of these cases is very narrow, and we're just trying to get it down to the implant depth that will cover the implant completely in bone. So you can see that from the guided surgery, it takes away a lot of the unknown. What's the downside to guided surgery? What has been the downside? It's the cost. For a single implant, you can accumulate a fair amount of cost to get to the surgical guide. Now, today things are getting less expensive. The techniques are changing a little bit. But if you ask me why a lot more implants aren't placed guided, it's because these costs all accumulate. Make sense? All right, so if you look at the real costs of what were costs that I was paying here in practice years ago, these were the costs that I would pay for a guided surgery. You know, you can go anywhere from a single site, cost you almost $400, to 4 sites, cost you $700. This is why guided surgery works well for big cases, because years ago at $700, if you're putting in 4 implants, it's not a big cost. But if it's $385 for a single implant site, it's an expensive cost. And then if it's an edentulous case, the costs go up even more. So that's been the challenge, and I think part of the reason that the guided surgery hasn't really taken off. Okay, so I guess we covered that. Let's look at a case quickly. I know, Tim, I've showed this case for a lot of years, but the reason I'm showing this case is I want you to kind of understand what's been around for a long time. Look at the year. This is 2006. So in 2006, when guided surgery hit the market in 2004, 2005, in 2006, we already had the capability of placing multiple implants in the maxillary arch using guided surgery or the mandibular arch and building it to a decent outcome. So if you look at this case here, we're looking at the central incisors. This is the bone we have to work with. Here's the incisive canal. Here's the final restoration, a cross-sectional view. Can we tie an implant to this tooth? And if we can, it's a good implant site. If we can't, we go to a different site, do some augmentation, do whatever it takes. But what I want you to capture from this image is it's one image that gives you tons of information in terms of where you're going to place implants, what size, what angulation, what orientation. All those things are predetermined basically by this CT scan. So the treatment plan looks like this. And just quickly to go through this one site, this is a tooth number 3 position. We already know from this implant, we're going to place a certain diameter implant in a certain position to connect to this tooth. We're going to be in the sinus slightly, so we're going to do some sinus augmentation at the same time. So again, a plan for 14 implants, and that's the plan. So to go to the next site, we just simply move over and look at the next site. But you can understand the concept there. And then on the lower, the same thing. This patient had 14 implants planned on top and 12 on the bottom. And you might say, well, what are you doing that for? And the answer is there's no good reason other than we did. Maybe the patient had a titanium deficiency, and we were trying to solve that issue. So that is the treatment plan for that large case. Here basically is the surgery for a case like that. But again, I want you to capture not what we're doing, but this is 2006. So in 2006, we put in 26 implants guided. And I'm going to turn on the placement. Oops, I've got to go back. So again, you're looking at guided surgery here. So again, everything's guided. There's the one thing you're doing is you're basically drilling blindly. Now, if this was, it's obviously a large case. If this was a single implant case, the protocols or the process of doing guided surgery would be pretty much the same as what you're seeing. Just happens to be a case with a lot more implants. Those little pins on the side are stabilization pins. I think they're from Nobel. They hold the surgical guide in place and work as a pretty good cheek retractor too, as you can see there. But I'll move forward. The concept is that you're doing guided surgery on multiple implant cases. And then in this case, we're placing the implants through the surgical guide back in 2006. So you can see it's not necessarily a new technology anymore. So things have even improved since then in terms of diagnosis and treatment planning and surgical protocols. So there's your surgical guide going in place. When we're all said and done, in this case, we did the final restorations before we placed the implants. So all the final restorations were made. So they're not splinted together. We have a bridge here in front of the lower, but everything else is individual teeth. But understand what I just said. Back in 2006, the technology was good enough to place all the implants, have the final restorations made on an articulator, and put in the mouth after surgery. So if that was 2006, you can imagine we've made some improvements since then. But the bottom line is the technology is there, it's solid, it's not going away. So there's the picture taken that day when we put the implants in and all the final restorations, and it was dumb treatment because honestly we could have lost some of those implants. I'm not a big proponent of immediate placement, immediate load, but in this case we did it to prove or to see how accurate the surgery was. All right, so there's the final restorations placed the day of surgery, and that's his case 10 years later. So 10 years later, he lost his teeth because he was allergic to a toothbrush, hasn't done much hygiene or any hygiene since then, and even 10 years later, those cases look pretty solid. All right, so there is something to guided surgery. I think we can agree with that. Control is possible. I've just shown you a couple examples of it. I think it's better than this type of dentistry that is all too common in the implant world as well. So guided surgery is there. If you're thinking about getting into implant dentistry and you want to avoid problems, not like this one because this is outrageous, but afford angulation problems and things like that, guided surgery is your guarantee that won't happen to you. Not that you're going to do every place guided, but I think we can agree that approach is different than that approach, if that makes sense. All right, so let's move on. Something can be done about that. It's been one of the biggest challenges in implant dentistry. So control is possible. What are the challenges with guided surgery? We already said it, time and money. You need a fair amount of equipment to do it. Accuracy of the equipment and the surgical guides is always in question. Cost of the practice and the patient, learning curve to use the technology, those things are all barriers that you have to get through. If you look at reality of where we're at 2020, and this says that 2020 we're a little over 10% of the implants placed are used guided, according to this research, and next year maybe around 12% or 13%. So it's still a emerging technology. It's getting more straightforward, more streamlined with the digital flow. But it is there, and it certainly solves some problems going through the practice. So let's talk now about implant dentistry in 2020. What's different? What innovations are still coming? What processes are out there? So this would be a case I did in my practice a few months ago. The single cases that we said cost $300-400 initially, now I can do in the practice for less than $50 or whatever the case may be. But this is a surgical guide kit that has been developed, and it's for an anterior case or a posterior case, and I'll just walk you through how the process works. They come in different sizes for the patient that you're working on in terms of space between the missing tooth, but it's designed for a single tooth implant case. If you had a patient like this one with an individual implant needed, these impression trays are used to take an impression, and then the same tray is used to make a surgical guide. So in a sense, there is no merging of files. You take a CT scan with this in place. There's some radiographic markers here. First of all, take the impression. I'll walk you through the steps. Radiographic markers, you take an x-ray, 3D print the insert from treatment planning software that goes in that case, in the mouth, and the second time you see your patient, you're doing the surgery. There's drills now that are on the market that generate much less heat than drills in standard surgical kits. So if you cause less heat to the bone, you're able to restore the implants faster because the bone has less healing to do, and it's pretty well documented as well. So it's pretty common now if you're using this type of drill and this type of approach, put the implant in, use the drills that don't generate much heat. The body responds and heals quicker. You're restoring the implants now at 6 weeks rather than 6 months. So it's a fairly common thing that's happening now as well. So here's the implant that was placed, scanned the day of surgery or 6 weeks later if you want to scan it 6 weeks later, but basically it's a digital flow just to help you through the process again. First appointment, take impression, shoot the scan. Second appointment, place the implants, do your final scan for the restoration if you'd like. Okay, so that's what's happening here. You take a implant stability quotient measurement, day of surgery, 6 weeks later. If you're above 60, when you're ready to restore, that appears to be a safe number to restore your implant. So patient-specific abutments and crowns are very common today. That's what you're seeing here. almost never in my practice use a stock or standard abutment anymore. So there's your final restoration. So you went from surgery to final restoration in 6 weeks and basically 3 appointments, if that makes sense. So there's certainly a lot of time cut out of a lot of these equations, appointment time and appointments actually themselves cut out of that equation. All right, so let's look at a quick video of basically how that surgery went so you get a feel for what's available.
Hey, sorry. I have a question about the, oh, I can wait till after this.
What was the question?
Sorry. Do you want me to wait till after the video you're showing? Or?
No, go ahead. Well, actually, let me walk you through the video. Maybe it'll handle the question. Let me do that quick. So what you're seeing there is these are little inserts that come in 3 different sizes, and you're finding the insert in there that fits between those adjacent teeth. So that insert's a little bit, see the area here, that insert's a little bit bigger, a little bit smaller. You're finding the insert that fits into that space. So you're just measuring one of 3 choices. You have a posterior segment and an anterior segment. All right, so this is the one that was chosen for that site. You snap the 2 pieces together. And you're going to fill that now with impression material and seat it in the mouth. It's just a little adhesive here. Different impression materials of choice. This happens to be Impergum. I'm not sure I have found the one I like the best yet, but this seems to work quite well. But it's just a final impression material for crown and bridge. We tried bite material, but that was more rigid, but almost too rigid. So you center the blade over the site that you're trying to place the implant and just let it set up. Take it off and make sure you have good stability both in and out of the mouth. And if you do, you just take off the initial cap. And this has the scan cap that goes on top of that with the radiographic markers inserted. So you have those radiographic markers in place. So again, all this is done your first appointment once you've sold the case. So there's your 3D printed insert. So if you can imagine, you took the CT image, you put it in a treatment planning software. So the patient goes home after the x-ray, and this is what you do in the background. So that the long part of that, there's 2 sides. You can see the short side and the long side. The long side always goes to. I should use the straight explorer, but basically all I'm trying to show there is I mark but you get the idea of the flow, treatment flow. Pick a color, get your final restoration made, and that's my favorite restoration. Like I said, don't use too many standard type abutments anymore. This is a patient-specific abutment with a ceramic core and a ceramic crown. Healing cap comes off. Patient-specific custom abutment goes on. Torque to proper torque, and cement the crown. What I put inside the screw there is just plumber's tape, basically. You could put in there whatever you prefer. Cotton, plumber's tape, whatever. Just covering up the screw if you ever have to get to it. And there's your final restoration. All right, there was a question. I don't know who said it, but what was it?
That was me, Brian. I think I misunderstood you. I thought did you say you rarely use the healing, stock healing cap, and you make a custom tissue healing collar? Is that what you said, or no?
No, I didn't. I was talking about in a case like this where you had a choice of putting on a cover screw or a healing cap. I generally put on a healing cap to avoid that second stage surgery. But your question is more about tissue and emergence profile, I think is what you're getting at.
Yeah. Do you ever use custom tissue healing collars or anything, or do you not? Really
honestly, no.
Okay.
No, I honestly don't. But it's a good question. How do you get away from that? And I'll answer the question as honestly as I can. The right way to develop tissue is do exactly what you're saying. Use a custom tissue informer or a temporary abutment, build the emergence profile, take the impression, have the lab make the crown. What I tend to do is not do that because it takes time and share time to do it. What I tend to do is take the impression with the digital analog. Patrick, who works in the office, I say, Patrick, build me the best emergence profile you can build, which means that my circular emergence profile probably isn't going to be adequate. So when that crown or abutment comes back, I might have to open up the tissue to get it to seat, which is exactly what I do. Just use a bigger biopsy plunge, get rid of the tissue, seat the abutment and crown, and let the tissue grow back to it, if that makes sense.
Okay. Because I know with Implant Solution there in Wisconsin, with one case, I had to make a custom tissue collar. It was a little difficult to know where to put it down, the way they made it, designed it, but I didn't know if you use those at all with them, or if you, but it sounds like you don't.
I don't.
Okay.
No, I don't. I used a couple just to try them out and just realized that I could do it cheaper, quicker without them.
Yeah, no, that makes sense. Thank you.
Okay. Any other questions? Okay. All right, let's move on then. We're getting close to the end of it. So this restoration was at 6 weeks. And at 6 weeks, then this is a different case, but at 6 weeks, the same protocol. Check your stability. At 80, obviously, you're very safe to restore. So at 6 weeks, we're going to put in the abutment in the crown. So this happens to be a patient-specific titanium abutment with a ceramic zirconia, I think, zirconia crown cemented in place. All right, so final restorations look like this. You will notice that I place a lot of implants fairly subcrestal. And get back to your question. Can this be a problem if you go too far subcrestal and you build an emergence profile that causes a bone collision? And the answer is it looks like it would here, it looks better here. But you could build a abutment in the crown that causes a bone collision, and then we have bone profilers to get that bone out of the way so you can, even though you are hitting the bone, you can clear the bone away and get the restoration seated. So those are out there as well. And they're out there, obviously, they ideally be for any implant system that goes subcrestal because that is different. All right, so 2020, once the concept, packaged or fixed pricing, this is where we're going. A lot of companies are, and we are here also at Implant Logistics. So what we have in mind is we're going to provide a service that makes a custom abutment and a crown for $300. So the highest quality crown you can make, either titanium or a hybrid type abutment, for about a $300 focus. And if you throw the implant in on top of that, it's another $195. So ideally, we're restoring these cases in practice for about $500 from start to finish. Now, if you do guided surgery, there'll be some additional costs depending on what guided surgery you're using to do that. But again, I think if you can get these costs managed, then you can provide a service and still keep a lot of profitability in your practice. That make sense? All right. So if you want to get into implants in your practice, how do you achieve success? What is success? We're not going to talk about it in great detail, but this is what I consider success. Something that looks like a tooth when you're all said and done. So if it looks like a tooth the day you put it in and 7 years later, I consider that a success. And if you have an implant that looks healthy at 7 years, good bone volume, good healthy tissue with stippling and no bleeding, no probing and whatnot, that's a successful case. Are they all that way? Well, this is another case that has multiple implants. I think there's 13 years of stability. There's an implant for every tooth here, and the literature will tell you can't do that either. But you can with the implants that allow you to place them closer to each other and subcrestal. So there's 13 years of stability in that case, and I think if you had every case that looked like that, you'd do a lot of this. If you look at this case here, another implant that's placed well subcrestal, another one that's placed well subcrestal, cement that's been on there for many years, not causing a lot of bone loss. So I do have a disagreement with that approach that cements the antichrist of implant dentistry. Another implant placed subcrestal with very healthy tissue, not the same case, a different case, but that's what tissue should look like. If it's healthy, it shouldn't bleed. Why? Look at this case here. This is one patient. This implant is this implant. So this implant's failing miserably. This one's working well with all kinds of periodontal issues in the arch. Why is this one surviving, this one not? There's some information there that everybody should understand if they're moving into implant dentistry. All right, so again, I think just to kind of finish the conversation, because we're getting to our hour here presentation, if you look at implant success, what is the criteria for a successful implant practice, and how do you define it, and who defines it? What are the success rates in implant dentistry? Is success determined by bone volume and bone stability, and for how long? So all kinds of questions that I would ask anybody about, are they successful in implant dentistry? What's the tissue look like? Does the tissue bleed? If it is that successful? If the implant has significant bone loss, is that successful? So what is your priority, or what is your description of successful dentistry? That is all over the board, that I can tell you. With the virtual hundreds of studies that you'd like to reference to determine perceived success, which ones do you look at? Are implants really 95 or 98% successful, as many people say they are? And I would say, just as honestly as I can, not a chance. I don't think there's anything in dentistry we do that's 95% successful. I just don't believe it to be true, because we're fixing stuff. We're mechanics. That's what we do. But this is very common in implant dentistry, and this is why I think people are afraid of an implant handpiece that runs at 1200 RPMs. What people are afraid of is this. They're afraid of implants placed that don't hold bone over the long period of time and have no idea why it happens. That's really why I think most implants aren't placed, or most dentists don't get involved, is because this scares the hell out of them, and it should. If you look at cases like this that are done by specialists and then restored by restorative dentists or whatnot, and they turn out like this, a person with common sense will say, well, hell, if those guys know what they're doing and I'm new to it, why would I get involved? And I think that's the main reason people don't get involved. This pretty much, the solution to this problem has been my passion for the last 15 years. Because I would have to say to you, if you understand why bone is lost, this doesn't have to happen. So the prevalence of peri-implantitis, a lot of people say it's 95% successful. If you look at the literature and you look at the summary of all the literature that's out there, just to summarize, and that's what this is, all the literature out there saying that implant mucositis is in 19 to 65% of the cases. That's a big number. So if I read that right. Yeah, 19 to 65%. So what's mucositis? Inflammation, bleeding without bone loss. And if you look at the literature, it says somewhere between 10 and 40% of the cases that are done. So 10% is a low number, 40% is a high number. Of every implant case that's placed has significant bone loss and progressive bone loss. Well, if your idea for success is no bone loss, well, you're already at 60% success rate if you go with this number here. So there's a lot of issues that are out there. And I think an astute implantologist would try and understand what's causing the problem, how do we correct the problem, and what do we do to do that. So implant success could be, if you based on no bone loss, could be somewhere between 35 and 85% based on those numbers alone. So if 40% of all cases have peri-implantitis, we should be as concerned as a dental provider. So is cement really the problem? Is cement causing the problems with these cases here? And that's what everybody's talking about now. Cement's the antichrist of implant dentistry, and it's what's causing all these problems. It's the wrong target. It just really is. And I'm not saying cement's a good thing to leave in place, but cement doesn't cause this problem. So the long-term challenge, I think, with the implant dentistry, the biggest challenge is, the biggest success killer in implant dentistry is bone loss over time, potential implant loss. Maybe not implant complete loss, but implant aesthetics that's going south. All those things are a challenge in most implant practices. Real quickly, the two things that cause most bone around implants and natural teeth are these two things: biomechanics and bacteria. Implant or bone loss around teeth and implants is multifactorial, but these are the two big killers. And I think every clinical dentist kind of understands that you put too much pressure on something, or you have too much bacteria in the area, you end up with a root canal, a periodontally involved tooth, a periodontally involved implant. All those things are because of these two things. That's what we're really, as dentists, trying to control. All right. If one wants to get into implant dentistry and wants to be highly successful, I think it's imperative that one understands the etiology of these problems. And I want to, in my practice for 10 years, not really understanding the etiology of implantitis, or we had a feel for tooth gingivitis and problems, but not really implants. That seemed like it was a different animal, something different about titanium. So maybe this would be a good webinar to talk about additionally if we're going to offer additional webinars. I can't fix that problem in 20 minutes. It's a more lengthy conversation. But I can share, I think, with people and have tried to for the last 15 years of what have I done differently that have caused, not solve the problem, but certainly caused a lot less bone loss around implants on the implants that I place. So again, if you want to create a multi-million-dollar practice, maybe that would be a good webinar too. How will you do it, even in your own clinical practice? I would consider learning how to do the #1 service that people want, and that's show me how to take a tooth out, put an implant in the same day, and restore it predictably. You could get rid of a lot of the guided surgery. You can get rid of a lot of the costs of implants. If you could, in a general practice, just do that, I think you can have a very productive, very profitable implant practice, solving a problem which patients come in for, tooth broken off at the gum line, can you replace it with something? And if you do implants well, most of the time, your bridges are probably going to go away and your implants are going to replace those teeth because in most cases, especially on the young patients, it's the right thing to do. All right, so extraction with implant placement, what do I mean by that? If you look at a case like this, you've got 1, 2, 3 teeth that are going to go away. If you take those teeth away and you can learn how to take them out, put implants in the same day like you're seeing here, graft if you need to, and restore those cases, it becomes a pretty productive, profitable process that you would do in implant dentistry. So again, implants placed at crest or below, grafted appropriately, appropriate time, healing response, and then you're going to restore those cases with patient-specific abutments and crowns and charge an appropriate fee for it, which they're happy to pay. So that's what you'd end up with when you're all said and done. But I think that's an opportunity for any general dentist that wants to get into implants. It's an opportunity to get into it. It's a lot easier with today's approach than it was 15 years ago. Because the ability, like I said, to place implants at crest or below makes this process a lot simpler. A lot of people have told you in the past it's a difficult thing to do. It's really not. They just have to understand what you're doing and how you're doing it. These implants that are out there today, for example, not just ours but others, if you can place an implant below the crest of bone, many times now, almost always, I'm taking teeth out and putting implants in, even if you've lost the whole buccal plate. As long as you get the implant away from where you're trying to grow bone, you can grow bone. If this implant's buckled to this space, it's not going to work. But this is pretty well protected here. It's not hard to grow bone from here to here with the right approach and the right technique. So again, if you can take a tooth out, put an implant in, and conserve all this bone that's here, you'll have a nice aesthetic restoration when you're done. This is easy to replace. Vertical bone loss is very hard to replace. So that's what I'm always conscious of. Can I keep the adjacent bone in contact with the adjacent teeth? If you can do that, you can almost do anything out here. So that's, again, another way of doing it.
Got a question.
Yeah.
From Josh. Thoughts on tie base use for restoration?
Tie bases? Yeah. Yeah.
Your thoughts.
My thoughts on tie bases used for restoration? Is that the question?
Yeah.
Okay. Yeah, tie bases are very popular today. A tie base, or they're called different things, but I think a tie base is probably the #1 restorative option that we do on most of our implants today. Now, if you're tying all the teeth together, the connection might be slightly different, but for an individual tooth, a titanium connection with a hybrid zirconia core is what I call a tie base, and again, that's probably the #1 restorative option that I do. All right, I hope that answered the question. In this case here, just to finish up, grafted and done. The all on everything. I'll be honest with you. I truly believe in an all on 3, 4, 5, 6, 7, 8, whatever the number is. I'm not a big proponent of immediate load. So in this case here, this was basically an immediate load case, just to kind of show you what the variety of this approach is. These are upper and lower full zirconia appliances. If you look at the case here, you've got 1, 2, 3, 4, 5, 6, 7 implants on top and 5 on the bottom, and the spacing might seem a little weird to you, and let me show you why. This is the case. He's an elderly man. We are going to take out all the rest of his teeth, but he was functioning okay on these teeth. We had an upper and lower partial. So rather than losing the vertical and reestablishing all that I think this guy was 80 years old, we decided we were going to place implants where teeth were missing and let the implants heal, let him function with his teeth. And then we were going to make those final restorations, put them in place, as you see here, the day we take the rest of the teeth out. Now, again, we put in all the hybrid type of appliances or hybrid type of abutments. These are all full arch zirconia. Obviously, they're cemented with temporary cement. As these sockets heal up, we're going to pull these things off, We're going to add more porcelain if we need to, and then re-cement it, 4, 5, 6 months from now. You could re-cement this thing with temporary cement for the rest of his life if you wanted to, and take it off every 6 months. I don't make appliances that I have to unscrew every 6 months. It's a royal pain in the what. So I will either make them permanently cemented if they're all crown and bridge material, or I'll put them on temporary cement and pull them off if I need to down the road. But with that many implants, the stability is not going to be an issue. But I don't personally make screw retained full arch restorations. I find them to be challenging. So just another approach or another way of looking at the all on something. My biggest disagreement with the all on everything and loading them the same day, you got to reduce too much vertical bone to get good stability of the implant so that you can load them the same day. So I tend to avoid that. So that's kind of what I wanted to present. I'll leave it at this. I'm here to help. If you found the presentation useful and you'd like to expand or dig deeper on any of the things that we talked about or anything else for that matter, be happy to do it while we're all shut down. All right, thanks. Any more questions?
Leo, I think Josh Conway had a question. Did that come through?
Okay, I can hear you now. Did you have them all muted before? Was that the problem? Okay, there's a question. I got to get closer to read it. Okay, go ahead.
What are your clinical criteria decision tree for deciding whether to restore 6 weeks, 3 months, 4 months, 6 months, or single treatment?
Yeah, that's a great question, Josh. That's a highly variable question because every case is highly variable. If I'm working on a case that's it's not a grafting case, for example, the tooth's been gone for a while, the bone's healed. And when you're doing your osteotomy, it seems like the bone has decent density, and you do the ISQ test the day you put the implant in. Let's say the ISQ tells you it's 65. So you got a pretty stable implant day of surgery. I would probably wait 6 weeks and restore that case. But then when you restore the case, you do another ISQ test, and if you're above your initial, you're above 60, for example, you're safe to put the restoration of crown in place. Let's take that same scenario. The only difference is when you put the implant in, the bone density was very poor, and instead of testing at 65, it tested at 35. Well, you have very, not immature bone, but a bone that's not very dense. Well, just doing the surgery is going to create a bleeding issue, and you're hoping during that restorative period or that healing period, that bone density is going to improve because you wouldn't restore any case at any interval at 35. But let's say you come back at 6 weeks and you're still at 35, well, it'd be crazy to restore it. If you're, on the other hand, wait 8, 10, 12 weeks and now you're at 60 or above, go ahead and restore. So I'm really using that radio frequency of the ISQ to tell me when I can restore. But then just use common sense too. If you're taking a tooth out and you're putting a tooth in an extraction site and you've really only got stability of the implant at the apex, well, there's no reason to bring that patient back in 6 weeks because if you grafted that case, that bone's not turning over in 6 weeks. That might take 4, 5, 6 months. So in that case, if it's an immediate extraction implant placement, grafting around the implant, you're probably 4 to 6 months waiting for that to heal because it just takes the biology of the human that long to work.
A couple more comments here. Zach says we'd love to see more webinars.
Fair enough.
Josh told me I don't know if they could hear me. I don't think he can.
Let me finish the question with Josh before I go on. Let's say, for example, you're doing a case with 6 implants. When would you tie that case together? Well, if you have 6 implants and you got good primary stability of all 6, you could potentially put a temporary on that day because you're tying them all together. Doing that to an individual crown is much more dangerous. So if you're going to tie them all together day of surgery, that will work. If you have poor bone density, I guess the bottom line, you're just going to wait longer. Where people run into the most trouble is they get stuck on it's 6 months or it's 3 months or it's 2 months and it applies to everything, and it never does because there's too big a variable in the cases themselves. I would say to you as an average or as a guideline, if you're putting an implant in grafted material, the graft material that you're using really has more weight on when you can restore than the implant itself. Certain graft materials turn over quickly, 3, 4 months. Some of them take 3-4 years. So you have to be pretty careful and understand what graft material you're using around an implant as well. All those factors are there. So don't ever get caught with the idea that 3 months works for everything or 6 months works for everything. Time's your friend. But if you're going to push the envelope inside that 4 or 6 month window, have a reason to do it.
I think I put a question up on the screen for you. You read it back.
What are your must-have when you are evaluating an implant line? That's a great question. Well, obviously, I developed an implant system, and I tried to put in mind what I thought was important. So I have my opinions and what works and what doesn't work. Today, I mean, and I'm not here to beat up other implant systems. It's like everything else. If you're going to take an implant that's been on the market for 40 years, unless that guy was really good at when he developed it, he probably had some things in that system that aren't bad. They're just old technology. And I look at a lot of the implant systems as just old technology. If you're using an implant system, the standard implants, Nobel, Straumann, 3i, 30, 40-year-old systems, if you're still using those systems, there's some things you can't do with those systems. You can't place them subcrestal. It makes immediate extractions, implant placement much harder. Those companies are all going to, if they haven't already, are going to come out with implants that can go subcrestal. So if you ask me, what do I absolutely need for an implant system? I need a really good system that can do everything robustly. What does it have to do? It has to be able to be used in almost every clinical situation. It has to be an implant that I can place at crest or below. It has to be an implant that is affordable. I think the day of the $500 implant is kind of over. At least it should be, because there's a lot of $200 implants that are every bit better than technology that's 40 years old. So I look at hexed implants, for example. When I say hexed, we didn't get into that today, but if I say a hexed implant is not designed to go below the crest of bone. And that's the way most of them were. They were externally hexed or internally hexed, designed to be placed at crest or above. Well, that handicaps you a ton when it comes to doing surgery, and it slows your surgical process and restorative process way down. It doesn't make them bad implants, just makes them old technology. The technology has moved past that, I think, is what I look at. So to summarize, implant that can be used in almost any clinical situation, affordable implant that can go subcrestal, and there's certain things that have to be in that implant for it to go subcrestal. If you cover those 3 things, and there's more than one system out there that does those 3 things, you've got a good implant system. It doesn't handicap you clinically.
Put another question on the screen there.
Okay, next question. With the guides, do you have room to lay a flap to preserve attached tissue, or are they really only best for cases when plenty of attached tissue? No, the guides themselves don't, since they're basically supported by the tooth. If you're talking about the 1-2 surgical guide that I was showing you, that guide doesn't dictate whether you lay a flap or not. And in fact, most guides don't. If they're tooth-borne guides and you want to lay a flap for a reason, absolutely lay that flap, because that will give you the ability to evaluate what's there. I don't think guided surgery is going to take away flaps completely. It never will, because there are certain things that you want to do surgically, and a flap is indicated. If you want to reduce bone, recontour bone, do a soft tissue graft, things like that, all those things require laying a flap. So that guide that I showed you for that single case, posterior case, that's a tooth-borne guide. So what you do with the tissue is kind of independent of that guide. If you lay a flap and move the tissue, then obviously you're going to want to make sure that tissue, if it's reflected, doesn't stop your guide from going in place. But other than that, there is no limitation to it. Are the quick surgical guides available yet? That's a great question. They're available in my office for my use, but they're not available out there yet because we're working on software to make the case go better. The software that we're using right now is a little clunky, and I don't want to release it until we have a better software. So we have a couple companies that are currently working on importing this into their software. I can't tell you exactly when they'll be available. The parts and pieces are all done. The protocol is all done. We're just working on software. We're hoping that exocad is the one that will help us, because if exocad, that's a massive software, would be our best integration, I think, with that software. It'll be an inexpensive software to purchase. If you want to purchase, you can get somebody to treatment plan for you as well. Are the Lucid Smart drills better than internal irrigation for reduced heat? Yes. And again, I said earlier, if you're going to quote me, date me. There was a time in my career that I said, if you didn't do internally irrigated drills, you're asking for trouble. Well, when you really drill down on the literature and you really understand what's going on, the problem with internally irrigated drills is you can't put any pressure on the water because you're drilling into a bone, and the drills get clogged, and there's not much water getting to the source of heat, which is the end of the drill or the side of the drill. So if you could put more pressure on the water, it would be awesome, but you don't. So a lot of times you get clogged. So nothing wrong with internal irrigating, but it wasn't giving the heat reduction that I thought it was doing because there's just not enough pressure coming out of the unit. So that answers how internal irrigation helps you. The Lucid drills, they're not my design. They were designed by someone else, but they've been well tested and they were designed in Germany. What they do is they generate a lot less heat when you're rotating. And they are reusable drills and they can be used multiple times. But like any drill, if it gets dull, it's not going to perform the same way if it's sharp. So I think most any drill, you use it 10, 15, 20 times, you should replace it, especially if you're using one drill for the whole drilling process. The drill that does the most damage, according to the research, and does the most work is a pilot drill. So you've always been told replace your pilot drill every so often. I didn't realize how much heat was generated by the pilot drill until you started using you started looking at the literature. But these drills, they cut quicker. They're more like weapons than drills. They cut quicker. They remove the debris quicker. And that seems to be the two things that cause less and less heat in that area. And again, it's not my research. It's well documented. And again, I was never a proponent of loading implants that quickly, but it's proven to me now that if you do everything correctly, not every case, but a lot of your cases are ready to be restored at 6 weeks. And that's just new to implant dentistry. Okay, thoughts about osteodensification DENSA system. Do you see a situation where you use it or not use it? It's a totally different protocol than the Lucid drills, but it's got validity. If you're working on a case like I described earlier, where you're doing an osteotomy, and we've all had that experience and they're doing implants, you go through the cortical plate and you fall into what feels like styrofoam. There's no density there whatsoever. So in a case like that, many doctors would say, well, they do the pilot drill and then they'd use osteotomes to expand the bone or condense the bone. And it was a good approach, but the osteodensification drills actually do an easier, faster job of that. So in cases like that, the less bone you can take away and the more bone you can compress, the better you can do it. You don't want to use that drill, though, in my opinion, for cases of dense bone, because now you're generating a tremendous amount of heat again. You're doing exactly the opposite of really what the bone wants. So if you need to cut bone away, and maybe to summarize, you want to cut it away as efficiently as you can and create as little heat as you can. If you want to densify bone, then the right drill for that would be those what are they called? Osteodensification burrs from Densa. I have them in the office. I use them a lot for that when I need that, and I also use them for sinus bumps because they work really well for moving bone up into the sinus, rotating counterclockwise. So I tend to use those drills quite a bit actually in the posterior maxilla and for sinus bumps, but virtually mandible in most cases.
Hey everybody, I know Leo's gonna be gonna do another presentation. Leo's gonna do a presentation Friday. And if you guys want to email me some topics deeper for next, you call me or whatever. And Brian had another question.
And I don't have so much a question as the last 12 years I've used Zimmer. They seem a lot more efficient than Zimmer drills that I've used about the design and everything. And I could definitely say I like just how smooth they go and everything is. I found Zimmer I'd use a lot of pressure a lot of the time, especially for dense bone, but whatever that drill design is, it's a lot nicer.
Yeah, well, thanks for that. There's a lot to what you just said. Drills that had a little different design, but there was really no research on drills whatsoever. Everybody made a drill. They didn't have any science behind whether they cut. You get the feel for whether they cut efficiently or not, but you had no science on whether they were generating heat or not. If you think about bone cells, I mean, there's plenty of ways to kill a bone cell. Bacteria is one of them, but heat is certainly the second one. The only thing that's changed in my protocol is using a drill that generates much less heat. And I didn't take it for gospel truth until I tried it. When I was restoring cases at 6 weeks, it really changed my attitude on how important drills are. But I also didn't understand. I always had the idea that if you used a pilot drill and it wasn't all that sharp, no big deal. You're going to remove the bone. By the time you get yours, it's just the opposite. That pilot drill generates heat almost 20 millimeters from the point of contact. Well, that's bigger than all your implant you're putting in. So killing a whole lot of bone. And if you did an implant that fell out 2 weeks, ask anybody why they were hurting, because you just killed too many bone cells. So all those things are there. A lot of the implant companies now are going to not a less of a drill protocol. Usually that makes sense. But Zimmer, I placed thousands and thousands of Zimmer implants in my because that's what I used initially. It's a good implant system.
I know, I totally agree. And I like the threads on the implant one too, a lot more, obviously more aggressive than Zimmer and everything. Zimmer still switch over to implant one and appreciate a lot more.
Awesome. We're glad to have you. And I'll be just honest. Obviously, I have a dental practice I'm trying to keep in business, and we have an implant. Any other questions? Are we good?
So Leo, I was just going to mention that as we build this, it seems like every time we talk to people, they have a high level of interest in at least learn. Make sure everyone knows that you're more than willing to come out and do a real interactive, maybe even hands-on type course out in the Spokane area. That's when all the fog lifts from the funk that we're all in the middle of. Yeah,
Absolutely. If you have interest, that's what I'm looking for.
Thank you, Leo.
If you wanted to hear about why they're at home looking for something to do, just let me know. I can put together what is it that you'd like to know and make it short and sweet and give you some useful information on that.
That'd be.
Thanks, everybody. Thanks,
Appreciate
Leo.
it.
Thank you.
You're done?
I think that did it.
Okay.